Give it to me. So, good afternoon. Thank you for being here. It's the end of a long day, and I appreciate your staying this long to listen to me. I'm going to be talking a little bit about our clinical experience that we've had with the therapeutic applications of stem cells, adult stem cells, and specifically autologous adult stem cells. I'm an assistant clinical professor of cardiology at Nova Southeastern and a professor of cardiology at Edison State. Interestingly enough, right now we've actually got students from the cardiovascular program at Edison State rotating through our offices and clinics and seeing patients before, after, and even some of the stem cell applications that we're doing. So it's very exciting to be able to relay this educational process to the students that are going to be working in the cath labs in the future with cardiologists and other physicians in other fields in treating patients with stem cells. All right. To give you an idea, and you know most of this, degenerative disease is a major cause of morbidity and mortality in the United States and in the world. It's the largest single expenditure for Medicare, and if we were able to save some money for Medicare, this would be the area that we would want to apply it in. The largest expenditures for hospitalizations for congestive heart failure, and that's when the patients end up back in the hospital because they're filling up with fluid. The only therapeutic option is heart transplant, and most of the patients die waiting for the transplant. Where do we get stem cells from? Obviously, we've got our non-embryonic and then the embryonic, which has been the controversy. Just to give you a brief outline, we've not been able to use embryonic stem cells to date in the treatment of adults or humans. There has been some misspeak using the word embryonic and meaning things such as umbilical and or aborted fetal tissue cells. But true embryonic stem cells come from the blastocysts that are derived from fertility clinics. And we have not been able yet to prove the safety of these cells in treating humans. The other interesting thing is that those embryonic cells are somebody else, so we have to use immunosuppressive medications if we were to use these cells in humans. There was a trial that had gained initial approval by the FDA. The Geron Corporation had put that forward, but it's had been halted again because of the high propensity for teratomas and cancer risk that they saw in the animal studies that they were doing. In order to decrease the risk of cancer and or teratomas, the cells are matured. But when they're matured to the point that the cancer risk is acceptable, whatever that might be, we lose the regenerative power of those stem cells and therefore lose the quality that we're looking for in these cells themselves. And lastly, of course, is the controversy. Now, we've come up with some induced pluripotent cells. You might have heard of these. These are cells that come from the skin most recently. An American and Japanese team was able to take cells from the skin and retroprogram them back into embryonic-like cells, but we still end up with the same problems that the embryonic cells have, with the exception, of course, of the controversy. So again, we haven't been able to use these cells for treatment. Non-embryonic fetal stem cells from aborted fetuses, cord placenta, we've been saving a lot of cord cells recently, and then what I like to call adult stem cells that come from the patients or from true adults. We see them in the circulation, blood circulation, bone marrow, as well as fat and other organs. Fat obviously is another big source for stem cells, and we'll talk about that a little bit as we go through. All right, our experience has been predominantly with blood-derived stem cells, but we work with all other sources of stem cells as well, depending on the patient and the disease application. The source that we have is we'll take about 250 to 300 cc's of blood. We'll separate out the stem cells using a density gradient, and then we'll take those cells and we'll grow them and differentiate them using various growth factors. Once we end up with the product, it takes about 5 days. We have a large number of stem cells that have a certain degree of differentiation as well as expansion as far as the numbers go. The nice thing about these cells is that they actually secrete cytokines and other interleukins that will recruit further stem cells to the area of implantation. We'll then take those stem cells and put them in the heart, lungs, or whatever else it is that we're treating organ-wise. So the important thing about these stem cells is that there's a high viability, that they've been proliferated and they continue to proliferate, that they've started to differentiate, and by doing that, they actually cause an induction of regenerative factors, recruitment of additional progenitor cells from the rest of the body, and then once those stem cells arrive to the area, they will those will be induced as well to proliferate, differentiate, and also exhibit regenerative properties. The nice thing about these cells is because they're adult stem cells, the body itself regulates their physiologic activity. So we've coined the term regenocites, regenerative cells, and they're cells that are different from basic stem cells, whether you get them from bone marrow, fat, blood, individual organs, in that they've been activated utilizing naturally occurring growth factors. And what we see is that they have high numbers of regenerative factors that are produced by the cells. This is a flow cytometry chart, and it kind of shows you the differing receptors that we see on the cell population that is derived from the growth factors. And just to compare them to, for instance, a stem cell that comes from fat or from bone marrow or just circulating, you'll see that, for instance, the interleukin-8 production is 10,000-fold a activated cell as opposed to one that is just plucked out of the organ or the circulation. And that's extremely important because interleukin-8 is the interleukin that recruits other circulating stem cells to that area. And this was actually very, very elegantly shown by Joshua Hare at University of Miami. They did a study utilizing pigs causing infarcts and using immunofluorescence. They were able to show that new stem cells would go to the area of damage where the stem cells that had originally been implanted were recruiting the circulating stem cells. So what do we do once we've grown these cells? We put them through a battery of tests. This is all based on US FDA guidelines. Make sure that there's enough cells, they're sterile, no endotoxins, no mycoplasma antibodies, high viability. The morphology, these cells will actually morph from a large nucleated stem cell into a spindle-like endothelial cell, for instance. And I'll show you some other cell morphologies as we go on in the talk. Whoops, sorry about that. And then also we look for surface markers using flow cytometry. This is all published. It's in the British Journal of Hematology, 2006, and I can give you this reference after the talk if you're interested. Basic research, we took rodents, induced a anterior wall myocardial infarction, gave them back some human stem cells. They were nude rats, so they had no immune defenses. And we found that the human stem cells actually engrafted in the infarcted area of the myocardium of the rat. So we were able to prove that stem cells will engraft in areas of infarct. Excuse me. Not only did they engraft, but they differentiated and matured into myocytes by staining for cardiac troponin, which is exclusively a human cardiac enzyme. So now we were able to show that stem cells can in fact start to form new heart cells in areas of previous infarction. And what else did the cells need? They needed neovascularization, so they actually generated new blood cells to the area of the infarct. This was very nice because what it did was it increased the ejection fraction for the treated rats, and the rats that were not treated obviously had a decrease in their ejection fraction after the infarct. This also has been shown clinically. Joshua Hare, again, at the University of Miami, was doing a study using Osiris's mesenchymal cell product. It's in a phase 2 trial right now where they were using these cells, the cells from Osiris, for acute myocardial infarction, and they were able to show increased ejection fraction, heart function at